Hello, this is a video lesson on the upper extremity. So as far as exam preparation is concerned, we want to make sure that we remove all artifacts from the anatomy of interest, secure all patient possessions in designated manner and location, have the patient seated at the end of the x-ray table lateral to the table, so we don't image we're not imaging the gonads. We want to do everything tabletop as far as these projections, and there's no grid necessary. We want to use close collimation, always use our ID markers, and for all projections of the upper extremity, they're all performed at 40-inch SID. And finally, we always shield the gonads. The fingers, we have the different projections we're going to be looking at. For the second to fifth digits, we're going to image the entire hand. Then we'll talk about imaging just the PA projection of the finger only, the medial and or lateral oblique of the fingers, and then the lateral projection of the fingers. For the thumb, we're going to look at the AP, the medial oblique of the thumb, and finally the lateral projection. So let's begin with the PA projection of the hand. So the patient is seated at the end of the table. The forearm rests on the table as well. The palmar surface rests on the image receptor, and we're going to center the image receptor to the metacarpal phalangeal joints. And the long axis of the image receptor is parallel with the long axis of the hand and the forearm. You want to spread the finger slightly, and then you want to direct your central ray perpendicular to the third metacarpal phalangeal joint. You want to include collimation with 1 inch on all sides, even 1 inch proximal to the ulnar styloid. And we're going to see PA projections of the carpals, the metacarpals, the phalanges, with the exception of the thumb. The thumb will actually be in an oblique. And it also shows the distal radius and ulna. So taking a look at the image that's shown here, we're going to ensure that we have collimation, that we have anatomy from the fingertips to the distal radius and ulna, that we separate the digits with no separation, no tissue overlap. We want no rotation. We want equal concavity of the metacarpals and the phalangeal bodies on both sides. The fingernails are visible in the center of each distal phalanx, and we want to have open MCP and IP joints. For PA projections of the second to fifth fingers, we're going to do the same positioning as we did for the hand, except we're going to separate the digits slightly, and we're going to center to the digit of interest. We're going to center now are being perpendicular to the pip joint of the affected digit. We're going to collimate on all sides of the digit, including 1 inch proximal to the MCP joint. And then we're going to do a PA projection of the appropriate digit in the adjoining distal metacarpal. We're taking a look here at one of the second to the fifth digits that happens to be the third. We're looking at having all three phalanges on the image as well as the head of the third metacarpal is on the image. We want no overlap and we want equal concavity on each side of the phalangeal bodies. The IP joints and the MCP joints should be open as well. When we're doing a lateral oblique projection of the second to fifth digits, we're going to make sure that we perform this with rotating the hand laterally until we have the digits are separated and supported with a 45-degree sponge. We want to make sure that the wedge supports the fingers so that they are parallel with the image receptor so the IP joint spaces are open. We want to center to the pip joints of the affected digit, and we want to have the collimation same as it was for the PA projection, where it's 1 inch on all sides, including 1 inch proximal to the MCP joint. So we're going to see the head of the metacarpal, of the affected metacarpal. We're going to see a PA oblique projection of the affected digit and adjoining distal metacarpal. And here is an oblique projection of the finger. It's rotated at 45 degrees, and how we know that is that we have concavity on the elevated side of the phalangeal body. There's no superimposition of the proximal phalanx or metacarpal phalangeal joint, and we have open IP and MCP joints. When we're performing a lateral projection of the second to fifth fingers, we're going to make sure that we either do a lateral to medial or medial to lateral, depending upon which fingers we're imaging. We're going to make sure that when we're imaging the finger, we're going to extend the affected finger with all other fingers flexed with the thumb. We're going to support the elbow in a sandbag or a sponge to bring the digit into position. The second and third digits are going to be imaged with the lateral surface of the hand in contact with the image receptor. So as shown in the top picture, we're looking here at the second digit being performed. That is the lateral surface that's on the image receptor. So we're doing a medial to lateral in this case. On the fourth and fifth digits, which is shown in the image below, we're looking at the medial surface being in contact with the image receptors. That is a lateral to medial. We may need to use a tongue depressor or some type of device or tape or something to support to hold that finger out. We want to make sure we see the entire distal, middle, and proximal phalanges of the affected digit. So we're going to adjust the hand to a true lateral. We want to then also ensure that our central ray is directed perpendicular to the pip of the affected digit. We want to have collimation 1 inch on all sides, including 1 inch proximal to the MCP joint, again, just like we did in the PA and the oblique projections. So looking at this image, we're looking at the entire digit, including the distal, the middle, and the proximal. There's a slight mistake here. We would probably like to get a little bit more of that, the head of the metacarpal, but it's understandable. We have no superimposition. We want to make sure that the fingernail's in profile, and we've got a concave anterior surface of the phalanges that we can see here. We also want to see open IP joint spaces. Now, when performing projections of the thumb, we're going to perform, first of all, the top picture is looking at an AP projection. So in the AP projection, we're going to make sure that we internally rotate the hand. We're going to place the hand in that correct position so that we've got extreme medial rotation, hold the extended fingers back with tape or the opposite hand, and rest the thumb so that it is in a true AP projection. If the elbow is elevated, put a sponge or support underneath it. So we're going to make sure that the long axis of the thumb is parallel with the long axis of the image receptor, and we want to get a true AP projection and hold those 5 metacarpals back as far as we possibly the 5 metacarpals back as far as we possibly can. So we want to center to the first metacarpal phalangeal joint, and we want to make sure we have 1 inch on all sides of the joint, including 1 inch proximal to the CMC joint. We want to include the carpometacarpal joint. We want to see an AP projection to the thumb, the first metacarpal, and including the trapezium should be visualized as well. Now, if a patient cannot internally rotate the hand, we do have the PA as an option. All we do there is we have the patient basically in a lateral projection with the hand, and we're going to put the thumb is going to be positioned so that it is in a perfect PA projection, and they're holding using a tongue depressor to do so. So looking at the image, we're looking at letter A being the distal phalanx, B being the interphalangeal joint, C being the proximal phalanx, D is the metacarpal phalangeal joint, E is the first metacarpal, and F is showing the trapezium. So we want to see concavity on both sides of both the phalangeal and the metacarpal bodies. We want to see the thumbnail if possible, and we want to see open IP and MCP joints without overlapping. Now the PA projection will be magnified compared with the AP projection. Next, we have the oblique projection of the first digit. When we're doing the oblique projection, we're going to just basically put the patient into a the hands in a PA projection. We're going to separate so that we do have that thumb is still going to be long axis. The thumb is in relation to the long axis, the image receptor. So we want to alter or deviate the hands to make sure that we achieve that. And we want to center to the first MCP joint again. We want to have the 1 inches on all sides of the disc joint, including 1 inch proximal to the CMC, just like we did previously on the AP projection. And we're looking at a PA oblique projection of the thumb and the first metacarpal, including the trapezium. So keep in mind, you're always going to center to the first MCP. So looking at this, we're looking at the proper concavity of the elevated side of the proximal phalanx, just like we did with the 2nd to 5th digits. And we're going to see the area from the tip of the thumb to the trapezium is included on the image. The lateral projection of the first thumb is performed very similarly to what we just did for the oblique. However, we're going to arch the fingers. So we're going to have the palmar surface down, the fingers flexed or resting on a sponge, and that way we can arch the hand to it till we get a true lateral projection of the thumb. We're still going to center to the first MCP joint. We're going to make sure we have the same collimation, and the structure is shown as a lateral projection, including the thumb, the first metacarpal, and the trapezium. So looking at our images, we're going to go from the distal end of the thumb to the including the trapezium with no rotation. We have concavity on the anterior surface of the proximal phalanx and the metacarpal. The thumbnail should be visualized in profile. We should also have open interphalangeal and metacarpal phalangeal joint spaces. Now comes the hand. The hand there's only 3 projections of the hand. There's the PA projection of the hand, the lateral oblique, and the lateral projection of the hand. So starting off with the PA projection of the hand, we're going to have the patient seated at the end of the X-ray table with their forearm resting on the table. This is going to be with the palmar surface on the image receptor, and we're going to center to the image receptor to the MCP joints. We want to make sure that the long axis of the image receptor is parallel with the long axis of the hand and the forearm, and we're going to spread the fingers slightly. We do not want superimposition. We're going to center perpendicular to the 3rd MCP joint. We're going to have 1-inch collimation on all sides of the hand, including 1 inch proximal to the ulnar styloid. And our projection is going to show a PA projection of the carpals, the metacarpals, the phalanges, except the thumb will be in an oblique. We'll also see the distal radius and ulna. And so there we are. We've got the evidence of the collimation. We've got the fingertips to the distal radius and ulna, no overlap of soft tissue, equal concavity of both the metacarpals and the phalanges on each side. We want fingernails to visualize in the center, and we want to have open joint spaces. On the lateral oblique projection of the hand, we're going to still do the exact same positioning, except now we're going to rotate the hand approximately 45 degrees from the PA projection laterally. So we're going to use a 45-degree sponge in order we could do that, or we could just have the hand in a 45-degree. The thing is that we want to make sure those fingers are straight so we can make sure that we open up the IP joints. We want to be perpendicular to the 3rd metacarpal phalangeal joint. We want the collimation just like we had on that PA projection as well. This time we're going to get a PA projection of the hand, including the distal radius and ulna. This is going to be good for looking for fractures and pathologic conditions. This does not show an oblique, though, of the thumb. So looking at your image, we're looking at the anatomy of the fingertips to the distal radius and ulna. The 45-degree of rotation that we have is going to be allowing us to see separation of the metacarpal bodies from the 2nd to the 5th, with the 2nd and the 3rd having the greatest separation. So more separation with these two. We've got partial superimposition of the 3rd, the 4th, and the 5th at the bases especially. We want open MCP joints. We want open IP joints when the fingers are parallel to the image receptor. That's ideal. The lateral projection can be performed either as a lateral to medial or medial to lateral. The lateral to medial tends to be more comfortable for the patient. It's just more of a natural type position to do. But you want the patient seated at the end of the table. I call this the karate chop position. So we want the lateral to medial, we want the ulnar surface down, we want the thumb side up. On the medial to lateral is the opposite. When the elbow is elevated, you want to support it with a sandbag if need to, but you want to extend the digits, and the first digit should be at a right angle to the palm. So you want the palmar surface perpendicular to the image receptor and centered to the image receptor to the MCP joints and midline to be parallel with the long axis of the hand and the forearm. On the lateral to medial projection, you're going to be perpendicular to the second MCP joint. For the medial to lateral, you're going to be perpendicular to the fifth MCP joint. So you want 1 inch on all sides, including 1 inch proximal to the ulnar styloid. You want the lateral projection of the thumb at extension, and it's going to present the position for localizing foreign bodies and position posterior anterior metacarpal fracture displacement is very important. The phalanges are superimposed. Now this is in extension. So with extension, something very important we're looking at is we're looking for foreign bodies, something very important, and we're looking for fractures. A fan lateral is also very common, and we're going to look at this one as far as being able to desuperimpose the phalange. So this is great to have a fan lateral sponge that we can still have the patient in that lateral position. They're going to be in a lateral to medial position now, so we're going to center to the second MCP joint. And the fan lateral, we're going to show almost all of the individual phalanges. The proximal phalanges are going to still remain somewhat superimposed, but otherwise we're going to see the remainder if we want to see the phalanges. And here's the extension lateral, showing that we would get a true lateral projection with the superimposition of the metacarpals and the phalanges. The thumb is free of motion and superimposition. It's truly right now in a PA projection. And then here's the fan lateral showing that was performed without a sponge, but it was performed so that we can see the phalanges that are desuperimposed now. And the final type of lateral projection that we can perform is the one with flexion. So this one is that we're going to do a lateral to medial. This one is performed where the patient is going to relax the digits to a natural arch of the hand so that the digits are perfectly superimposed. We're going to have them hold the thumb with a immobilized with taper the sponge, or have them hold it, and we're going to have them have the centering still to the second MCP joint. We still want the collimation to be the same. The purpose of this position is if the patient is unable to do the extension or the fan lateral. It also shows anterior posterior displacement in fractures of metacarpals. And here's the image of the hand, the lateral projection in flexion. We're going to see the anatomy of the fingertips to the distal radius and ulna and flexed digits. You want superimposition of the phalanges and the metacarpals. And this concludes our lesson on the first part of the upper extremity.